So it's a big mouthful, but हमारा जो CBEC forum है, we try to touch different topics. And उसमें हम साइंस को भी देखते हैं, कल्चर को भी देखते हैं, एथिक्स को भी देखते हैं. But also because CBEC Forum is our way of reaching out to people who are not just healthcare professionals, but also others, our public. So आजकल ये choice जो हमने जो आपको title मैंने अभी पढ़ के सुनाया है, this is because of some of the recent events that have been occurring with HPV vaccination. So ये जो है, it is just to help us, all of us, to understand कि ये जो vaccination drive जो है अभी, which is recently started last month, so we are seeing a very interesting repercussion against it from the public, and there are some who are in favor of it. Healthcare professionals also seem to be divided on this. So isme jo hai, there's been a lot of information, etc., and misinformation and disinformation that is available, and a lot of it ye jo hai my social media se hoti hai. So we felt that CBEC had to at least provide some input in this area, because we have the right kind of people. कि जो HPV vaccination आई है और इसके पीछे क्या था, what are some of the realities, but more than that, कि इस पे इतनी resistance क्यों आ रही है? Why is it that there is such a resistance to it? So आज का session जो है is primarily to look at some of these issues, और उसके अंदर जो है हमारे ये forum is always very interactive, and so we prefer कि discussions जो हैं उससे we learn more, and we have significant number of people also online, and we will make sure that we monitor that their questions also are taken into account. So, ek do points that I would like to point out to you. So, vaccinations, jo hain, they are among the most effective public health measures to benefit populations at large. This is something that we all know. However, if you look at it, this is a public health measure. So it's not a one-to-one clinical action or interaction between a physician and a patient and the family. So in this, the interaction essentially is with the public. And so the public needs to, I think, understand that this is for their betterment. Ab iske andar, I think both our speakers will touch on this area. But that means that your public has to be on board, has to understand what it is, and has been sensitized ahead of time. So HPV vaccination drive mein jo hua hai, I believe that step has been missing, and this is some of the areas that we will touch on. हालांकि HPV, हमने, if you look at our title, it's essentially, the title is from polio to HPV. And I think polio ki vaccination drives have been around for a very long time. Why is Pakistan still one of maybe two countries where polio has not been eradicated? And so I think what we can try to do today is to see if we can learn from some of the mistakes we have made in trying to eradicate polio. उससे हम कुछ सीख सकते हैं या नहीं? Compared to polio vaccination जो है is quite old. It came into, I mean, it's not a recent one. From the last century, it's been around. So वो HPV vaccination से कुछ मुख्तलिफ है, in the sense कि HPV vaccination is a relatively new vaccination. So FDA का पहला approval जो आया था, I believe in the United States, it was 2006. So we are in 225 now. So it's a relatively new vaccination. That means all the more important that people should know कि इसके facts क्या हैं, what are the things that are not true, what are the things that are true. And uske saath jo hai, can we collective wisdom mein, can we come to some kind of conclusion ke for this particular program, what is needed in order for the HPV vaccination to actually succeed in Pakistan? So I'm going to turn the mic over to Dr. Amir, who is going to be the moderator, and he will introduce our two speakers today. And I think we have exactly the right kind of speakers because they're the ones who have the knowledge, which certainly I don't possess. तो उसमें जो है Dr. Asma Naseem है. Dr. Asma is, Dr. Amir will give you the full introduction, but Dr. Asma is infectious disease background से आती हैं. And we have Dr. Natasha Anwar jo hai. She's a molecular biologist, so she understands the science, etc., of vaccines. So I hope that this will be an interactive session. And Dr. Amir, perhaps you can introduce.
Yeah. So, Dr. Mosen, thank you very much. We've actually introduced most of the, and if you could just take my face on the camera rather than my tummy. Thank you. I appreciate that. Although my tummy is not too bad also, but we've got two experts over here. So I'm delighted to introduce Dr. Asma Naseem. She is an infectious disease specialist and the head of department at SIUT and heading the department. And actually, she's created the department. She feels passionately about various issues and not only from the medical aspects, the clinical aspects, but also from the ethical aspects, which is why, which led her to do the postgraduate diploma in bioethics from our center some years ago. And she's been involved in the European Society, Ethics Society of Infectious Disease People. And I don't recall the exact name, but that's a society in which she's been very active on the European front, and of course in the Pakistani infectious disease societies, she's been very active. So she has a lot of very interesting insight into both polio as well as HPV, and she will help us reimagine this vaccination. And to take our imagination forward will be Dr. Natasha Anwar, who's joining us online from Lahore. Although I was insisting yesterday when we met in Lahore to bring her over to Karachi, but she refused. So she's our also our alumnus from the postgraduate diploma in biomedical ethics program, as well as the master's program in bioethics, and is an associate faculty of CBEC as well. She is a molecular pathologist working at the Khan University Hospital's lab in Lahore. She's based in Lahore. And she feels, again, she brings the scientific as well as the ethical aspects. So you will have both science, the clinical aspects, scientific aspects, as well as heavily influenced by the ethical angle to public health maneuvers such as vaccination, in which we will be looking at the current HPV and also reflecting on how we've managed to do what we have done with polio. So over to you, Dr. Asma. We will have, the format will be that we will have about 15 or to 20 minutes of a slideshow and a discussion with led by Dr. Asma, and then followed by a similar duration with Dr. Natasha. And then we will open it up for general discussion after both the speakers have given their deliberation. So hold on to your questions, write them down somewhere, and just post them after both the talks have concluded, so that some of your questions may be answered by the second talk also. That is why we are going to be having the discussion, and it will be a moderated discussion. Just keep your comments brief, introduce yourself, and make your comment, question, and then we'll have the response. So over to you, Dr. Asma.
Thank you so much, Dr. Amir Jafri and Dr. Fatma Azam. for giving a detailed introduction of our this topic on vaccination as a public health and from polio to HPV. So my agenda would be to discuss a brief history of vaccination, the worldwide, the global history. Then the status of vaccination in Pakistan. It's very important to delve into it. Okay, what's the status of vaccination in Pakistan right now? Then the very up and down story of polio, which I'll discuss in a few slides, and it's a long story, but I'll try to make it as short as possible. And then the last, and not the very least, but the very important thing, that human papilloma virus vaccine, which comes up in last month. I'll give the basic information, and then I'll over it to Dr. Natasha. She will delve into the discussion in detail about HPV vaccine. So what's the global history? These slides I have taken from WHO website. You can easily go and see. It's a detailed history of vaccination from time immemorial. So basically, from in 1796, Dr. Edward Jenner, he took out the fluid from the cowpox and inoculated in certain people, and he found that those people did not get smallpox. Hence the name. So he may be the pioneer of vaccine, and hence the name vaccine, which is actually after the word vacca, which is cow in Greek and Italian. Then the floodgate opens and a lot of vaccination come in, like rabies by Louis Pasteur, then diphtheria, antitoxin, then influenza pandemic came in 1918, and US military prioritized the flu vaccine formation. BCG vaccine came in 1921, 24 tetanus, and back in 1954, polio vaccine came in. So WHO planned a mass vaccination, the first mass vaccination program in 1967 against smallpox. And this was an unprecedented global solidarity was found, in which the two arch rivals, United States and Soviet Union, they came together and they allowed this vaccination to happen back in 1960s and 70s. So with the result of that, smallpox was eradicated within 13 years, and that was a major confidence booster for WHO and all around the world. And they proudly posted this thing that World Health Assembly declared the world free of smallpox in 1980. And because of that, they plan to have expanded program on immunization in 1974. And the plan was to prevent childhood diseases, mainly diphtheria, measles, polio, tetanus, tuberculosis, and whooping cough, and to establish a robust childhood immunization program all over the world to cover all the children. And this was also a great success, and is still going on. So after 50 years of the establishment of expanded program on immunization, the Lancet published this very interesting article. And they said that since 1974, vaccination has averted around 154 million deaths. And vaccination has accounted for 40% of the observed decline in global infant mortality. And this is huge. And this is a major thing. That's why the WHO declared that vaccines are one of the humanity's greatest achievement and one of the most impactful public health intervention. And then the WHO set a target of around 95% of children should be vaccinated throughout the world to prevent all these vaccine preventable diseases, WVPDs. So then what happened in Pakistan? So what happened to Pakistan regarding the EPI program? में क्या हुआ? EPI program was established in 1978, क्योंकि 1974 में आप याद करें कि WHO ने start किया. So 1978 में यहाँ पास आ चुका था EPI program, and this is the latest EPI program in Pakistan. Very effective, very nice, and this is proudly being presented on the website of the EPI people, where they said that under 15 up to 15 months 12 जानलेवा बीमारियों के लिए यहाँ पास इलाज है. So these बीमारियां are TB, polio, diphtheria, pertussis, tetanus, pneumococcus, Haemophilus influenzae, rotavirus, typhoid, measles, and rubella. So it is huge, and it is an excellent program which is on the website and is on the ground also. But let's see whether it's really on the ground or not. What are the problems or not the problems? So the EPI fact sheet of 2021, they reported that 76% of children at 2 years of age complete their full course of vaccine in 2021. And remember, the WHO said that it should be above 90%. So we are far behind. And what's the status of all the provinces? You all can see easily 90% in Punjab, but less than 40% in Rajasthan. A huge gap of unvaccinated children are here in Pakistan in the EPI, the basic EPI program. Then the WHO Emerald region, when I went into this website, I was again shocked to see that they particularly mentioned that Pakistan is the third among countries with the most unvaccinated or under-vaccinated children. And they said that 40% of the children who receive less than 3 doses of DPT are in Pakistan. So this is really sad. And so Pakistan continue to get help from different agencies. So World Bank also helped Pakistan, and they reported in 2021 that Pakistan has the second lowest coverage in South Asian region. And you can easily see that Sri Lanka, Maldives, Bhutan, and Bangladesh have more than 90% coverage. Wow. Bangladesh, see the Bangladesh. India is lower, which is really sad. And Nepal is also lower. Still, Pakistan is lowest, like 70 and 83% is this diphtheria and measles only. And Afghanistan. So Pakistan and Afghanistan are lower, but all our neighbors are doing very well in vaccination. This is the just basic EPI program. मुझे 12 बीमारियों का इलाज जो 15 महीने पे लग जाना चाहिए. So this is diphtheria, which is again published by the World Health. And diphtheria ki vaccination is going up and down in Pakistan. And we had a lot of diphtheria outbreak recently in Pakistan, unfortunately, because of these up and down of vaccines. And again, measles again has a slightly up and down trajectory, with measles, a huge outbreak in 2018 of measles. So still we are unable to eradicate those very, very basic diseases which are there in the West way back in 60s. And now we are still struggling with these diseases because of the lower immunization. And what's the reason they reported in the World Bank report? And interestingly, among all the reasons, the rumors, the technical problem, the main reason was, I was shocked to not exactly shocked, but very saddened to see that the mother education is the number one cause of children being not vaccinated. And this is really a eye opener for me, that all other rumors, सब जो है ना नीचे चले गए. अम्मा अगर एजुकेटेड होगी तो बच्चा वैक्सीनेट होगा, वरना बहुत कम होगा. So what's the polio story now? Let's delve into the polio story. So after the smallpox success, बहुत ज़्यादा overconfident हो गए हम सबके सब सारी दुनिया वाले, and we started imagining that we can easily eradicate polio also in 11 years. So in 1988, WHO launched the Polio Eradicated Initiative, and at that point, polio was endemic in 125 countries in 1980s. So just a little bit about polio virus. It's a polio virus. Has three strains. Polio virus 1, 2, and 3, and we have two vaccines: live attenuated vaccine and inactivated polio vaccine. Live attenuated vaccine, I'm so sorry. Okay, fine. So live attenuated vaccine are 3 types: trivalent, bivalent, and monovalent. Trivalent vaccine is being stopped now since 2016 because polio virus type 2 has been eradicated from the world. So now it's bivalent vaccine 1 and 3, and few monovalent are also being used these days. Inactive vaccine contain all the 3 strains, and the plan is to remove OPV completely from the world and just continue with IPV. But it's, until and unless we have eradicated all the the wild poliovirus.
Doctor, I just want to make sure the O and the I people understand.
Oral polio vaccine is OPV, and inactivated polio vaccine is IPV. It's inactivated polio vaccine, which is parenteral. It's not oral.
What's parenteral?
Injectable. I'm sorry, injectable. Yeah, injection through injections, and oral is oral drops of polio. So injectable polio vaccine or inactivated polio vaccine is being now introduced in Western areas where poliovirus is completely zero. And the plan is to phase out the oral polio right away after the eradication. But the one thing which is concerning is because the oral polio vaccine is live attenuated vaccine. So after a period of years of giving oral polio vaccine to children who have not been vaccinated very regularly, this vaccine-derived polio vaccine comes up, and it is basically the mutation of the live attenuated one in the oral polio. It gets mutated and become active and cause paralysis. So this is also a new concern these days, but they are also delving into it and try to reduce the vaccine-derived polio vaccine also, and they are now introducing a novel type of oral polio vaccine where they prevent this mutation to happen.
सर मेरा एक क्वेश्चन है, आपने बीच में भूल जाओ, अदरवाइज आई एम सॉरी फॉर
ओके
अच्छा ओरल आपने कहा कि अभी पाकिस्तान में तो जो भी हमारी ड्राइव चल रही सारे उसमें ओरल जो है वो पोलियो वैक्सीन भी सारे ओरल ही आ रहे हैं, और उसमें एक्टिव जो है इंग्रेडिएंट जो भी एक्टिव जो है उसके साथ रिकॉम्बिनेंट करके प्रोड्यूस किया जाता है। तो आपने जैसे अभी कह रही थी कि इसी एक्टिव की वजह से कुछ केसेस में पैरालिसिस देखी गई है, यही कहा आपने?
यस, अगर हम ओरल पोलियो वैक्सीन देते हैं और अगर हम इरेगुलर दे रहे हैं, वो बच्चा वैक्सीनेटेड नहीं है, तो पॉसिबल है, चांस है कि वो पोलियो डिराइव वैक्सीन भी एक्टिवेट होके और पैरालिसिस करा सकती है। लेकिन इसके केसेस आए हैं, अफ्रीका में बहुत सारे आए हैं, पाकिस्तान में भी आए हैं, लेकिन लेटली जो है इन्होंने अच्छा खासा कंट्रोल कर लिया है। अफ्रीका में तो ऑलमोस्ट जीरो हो चुका है, पाकिस्तान में भी इस साल कोई भी नहीं आया। इस साल जस्ट वाइल्ड पोलियो वायरस डेफिनेटली आया है, लेकिन वैक्सीन डिराइव बिल्कुल भी नजर नहीं आया। सो दे आर डूइंग द मेन जो इसका जो असल इलाज है वो ये है कि सबको वैक्सीनेट कर दिया जाए, तो इससे पे जो पोलियो डिराइव जो वैक्सीनेट डिराइव है वो नहीं आता फिर सामने। सो दिस इज द निटी ग्रिटी। लेकिन अब हम इसकी कहानी बता देते हैं आपको। ओके, सो 1988 में पोलियो ड्राइव स्टार्ट होती है। ओके, पोलियो ड्राइव स्टार्ट होती है। 1994 में अमेरिका से पोलियो खत्म हो जाता है। 2000 में वेस्टर्न पैसिफिक, 2002 में यूरोपियन एंड साउथ ईस्ट एशिया में इंक्लूडिंग इंडिया 2014 में पोलियो वैक्सीन खत्म हो चुकी है। पोलियो वैक्सीन खत्म होने की डेफिनेशन ये, सॉरी, पोलियो वायरस की डेफिनेशन ये है कि नो पोलियो केस एंड नो पोलियो वायरस इन द एनवायरनमेंट फॉर एटलीस्ट 5 years। सो ये चीज जो है इंडिया ने अचीव कर ली है। लेकिन अब जो है बीच में नाइजीरिया यहाँ पर नहीं है, लेकिन नाइजीरिया भी था, लेकिन अब नाइजीरिया भी अब आउट हो गया है, एंड नाउ ओनली पाकिस्तान एंड अफगानिस्तान लेफ्ट with wild polio virus circulation in the environment and among the children। So हमारी स्टोरी है क्या, कहानी क्या है, हम सारी दुनिया में हम दो क्यों रह गए? तो पहले अपनी स्टोरी बताते हैं, थोड़ी सी जरा खट्टी मिट्टी स्टोरी है। लेट्स सी। सो मास वैक्सीनेशन स्टार्ट होती है 1994 में फॉर पोलियो, ठीक है। 78 में तो EPI शुरू हो गया था, लेकिन 94 में मास वैक्सीनेशन थ्रू नेशनल इम्यूनाइजेशन प्रोग्राम एंड आल्सो सप्लीमेंटल इम्यूनाइजेशन प्रोग्राम। जो बार बार जो पोलियो वैक्सीन जो ड्रॉप पिलाए जाते हैं ना, वो सप्लीमेंटल इम्यूनाइजेशन प्रोग्राम कहलाते हैं। देन होता ये है कि 1997 में पोलियो वायरस 2 पाकिस्तान से खत्म हो जाता है। तो यस, हमने अचीव कर लिया, हम बहुत कॉन्फिडेंट हो जाते हैं, हम कहते हैं यस हम कर सकते हैं, इसका मतलब है। तो हम इसको क्या करते हैं, हम जो है और इंटेंसिफाई कर देते हैं, और अब हम हाउस टू हाउस शुरू कर देते हैं। पहले हाउस टू हाउस नहीं होते थे, लेकिन अब हम हाउस टू हाउस 1998 से शुरू कर देते हैं। इसके बाद क्या होता है, ओके, सो 911 हुआ और अफगानिस्तान में वॉर शुरू हो गई और केपीके में हमारे पास बेइंतहा इंस्टेबिलिटी हो गई विथ लॉट्स ऑफ पॉपुलेशन कमिंग इन एंड आउट, और डिस्प्लेस पॉपुलेशन बहुत ज्यादा हो गई और बहुत सारे बच्चे जो है वो वैक्सीनेट नहीं हो सके केपीके में। लेकिन वैक्सीनेशन शुरू कंटिन्यू होती रहती है और फिर ये कश्मीर का अर्थक्वेक आ जाता है। इसमें कश्मीर की जगह ईस्टर्न ऑफ पाकिस्तान में, ये नॉर्थ ईस्ट में जो है फिर दोबारा वैक्सीनेशन बच्चों को नहीं हो पाती। लेकिन पोलियो कैंपेन कंटिन्यू रहता है एंड हम फिंगर मार्किंग शुरू कर देते हैं क्योंकि हम देखते हैं कि कुछ बच्चे हो रहे हैं वैक्सीन, कुछ नहीं हो रहे, तो हम मार्किंग शुरू कर देते हैं, लेडी हेल्थ वर्कर को इन्वॉल्व करते हैं। लेकिन फिर क्या होता है, फिर ये होता है कि जनरल डिवोल्यूशन हो जाती है हमारी 2010 में, कि नेशनल प्रोग्राम डिवोल्व हो जाता है प्रोविंस में, फिर एक क्योस मच जाता है और इसमें शॉर्टेजेस हो जाती हैं, वैक्सीन नहीं मिलती, स्टोरेज का मसला होता है, प्रोविंस कंपनी जो है वो अपना कॉपरेट नहीं कर रहे होते, तो एक प्रॉब्लम यहाँ पर फिर शुरू हो जाती है नहीं सबकी। 2010 में फिर एक फ्लड आता है, अगेन केपीके में मसले मसाइल होते हैं, वहां पर फिर वैक्सीनेशन नहीं हो पाती, बल्कि इवन जो है पंजाब में भी नहीं हो पाती और सिंध में की बहुत सारी इलाकों में नहीं हो पाती। उसामा बिन लादेन, that was very very sad कि उसामा बिन लादेन was killed in Abbottabad through a fake vaccine campaign। दर्श पूरी जो आपकी वहाँ की जो कम्युनिटी है वो शदीद मिसट्रस्ट में डेवलप कर देती है और वो कहती है ये तो CIA का एजेंट है कि वैक्सीन पिलाई जा रही है, हम तो अपने बच्चों को हरगिज वैक्सीन नहीं पिलाएंगे। ओके, सो लेकिन वैक्सीन चलती रहती और हम वाइल्ड पोलियो वायरस को फिर इरेडिकेट कर पाते हैं। 2 को हम इरेडिकेट कर चुके थे और 3 को भी आखिरकार हम 2012 में इरेडिकेट कर देते हैं। वी आर डूइंग थिंग्स, यस, खट्टा मीठा है। लेकिन फिर क्या होता है कि फिर वहां पर हमारे केपीके में बहुत इंस्टेबिलिटी है, तालिबान है, एवरीथिंग। नॉर्थ एंड साउथ वजीरिस्तान में लोकल लीडर्स इशूड अ कंप्लीट बैन ऑन इम्यूनाइजेशन, दे डिमांडेड एंड ऑफ ड्रोन स्ट्राइक। तो अब ये होता है कि वहाँ पर इतने ड्रोन स्ट्राइक हो रहे होते हैं कि उन्होंने कहते हैं हम पोलियो वैक्सीन को मना करेंगे ताकि हमारे कुछ ड्रोन स्ट्राइक, एंड विच इज अंडरस्टैंडेबल कि वो जो है अपना अपना डिमांड कर रहे थे। एंड फिर वॉलेंट अटैक शुरू हो जाते हैं पोलियो वैक्सीन पे, क्योंकि हुकूमत नहीं मानती पोलियो वाली बात, तो ये वॉलेंट अटैक शुरू हो जाते हैं पुलिस पे भी और सब पे। तो क्या होता है, पाकिस्तान फिर जो है सेक्शन 144 बनाता है कि भाई ये तो बहुत ज़्यादा मसले मसाइल शुरू हो गए हैं क्योंकि लोग बहुत नाराज़ हो गए हैं, खासतौर पे केपीके में। और ये जो है मर्दान में सबसे पहले लगता है सेक्शन 144, और वहाँ पर जो है पेरेंट्स जो रिफ्यूज करेंगे उनको जेल में डाल दिया जाएगा। ये भी कहानी हुई थी, फिर आहिस्ता से उसको भी रिवोक कर दिया गया, वापस कर दिया गया। अच्छा, एक चीज, सॉरी, एक अच्छी बात ये होती है कि जो 2014 में एक बड़ी अच्छी नेगोशिएशन होती है बाड़ा के एरिया में, जहाँ पे 5 साल से वैक्सीनेशन नहीं हो रही थी, लेकिन जस्ट बिकॉज ऑफ गुड गुड कम्युनिकेशन एंड लीडर्स को इन्वॉल्व किया गया, तो ये मान गए और आखिरकार जो है ना 5 साल से नहीं होने से फिर अब वैक्सीनेशन शुरू हो जाती है 2014 में। पोलियो कैंपेन कंटिन्यू होती है, वो सागा कंटिन्यू चल रहा है, अप एंड डाउन अप एंड डाउन। 2015 में 304 केसेस थे, लेकिन वो 24 केसेस हो गए 2019 में, 18 में, 19 में फिर से आ जाती है क्या कहते हैं 127 केसेस थी, और अभी भी कहानी वही चल रही है। आफ्टर 120 राउंड्स ऑफ इम्यूनाइजेशन कैंपेन देयर आर 74 केसेस इन 24 एंड 29 केसेस इन राइट नाउ। तो अभी कहानी अप एंड डाउन, कुछ ये चली जा रही है। सो एक मैंने सो ये दीदी जस्ट मैं आपको बताना चाह रही हूँ, हॉटस्पॉट दिखाना चाह रही थी आपको कि ये पाकिस्तान के 2 हॉटस्पॉट्स हैं, एक ये नॉर्थ साउदर्न केपीके, कोयटा, एंड थोड़ा सा कराची में एक एरिया है गदाब का। यहाँ पर इन 3 जगह दीज आर द हॉटस्पॉट्स ऑफ पोलियो। एंड अनफॉर्चुनेटली बोलना नहीं चाहिए, मैडम डॉक्टर आजम नाराज हो जाएंगी, लेकिन दीज आर द पख्तून एरियाज एंड पख्तून स्पीकिंग वो वेल मैं वो ना करना चाह रही थी या इसको रेसिज्म नहीं बनाना चाहिए थी, लेकिन स्टिल दिस द रियलिटी के पख्तून डोमिनेंट एरियाज में ये कहानी चल रही है अभी तक।
But that's also the bordering region with Afghanistan,
Yes.
right?
So
So
these are
one would
because of-
expect that there is some.
Yeah. So this is the thing। और फिर ये एक सिस्टमैटिक रिव्यू है जिसमें डॉक्टर जे भुट्टा ने पब्लिश किया 2021 में। इसमें बैरियर्स बताए गए, तो बैरियर आप सुनेंगे तो आप कहेंगे ये तो कहानी चले जा रही है। तो बैरियर्स आर लैक ऑफ नॉलेज, अवेयरनेस, फियर ऑफ साइड इफेक्ट्स, कुछ समझ में आ रहा है, कुछ कहानी याद आ रही है, CIA एजेंडा, फियर ऑफ मेकिंग अ चाइल्ड इनफर्टाइल, ठीक है, नामर्द कर दे रहे हैं बच्चे को। एप्रीहेंशन अबाउट द इन्वॉल्वमेंट ऑफ फॉरेन एनजीओस, क्योंकि जब ये वैक्सीन की कैंपेन 2014 में बहुत वायलेंट हो गई थी, तो फॉरेन एजेंट्स बहुत आ गए थे, फॉरेन एजेंसीज बहुत आ गई थी, उन्होंने आके सारे वैक्सीन की हेल्प की थी। तो ये सबको पता है कि फॉरेन लोग आ जाते हैं, आगे गोरे आ जाते हैं हमारे पास। हराम इंग्रेडिएंट्स, कम्युनिटी फैटीग, इतनी दफा 120 दफा पिला पिला के आखिरकार कहते हैं भाड़ में जाए, हम नहीं पिला रहे बच्चे को अपने। तो लिहाजा कम्युनिटी फैटीग एंड वैक्सीन हेसिटेंसी इज देयर। लैक ऑफ ट्रस्ट, this is perennial. And then too much, this is last three things are very important. Too much attention to polio. Polio इस कदर attention है कि इस पेपर में इन्होंने कहा है कि बच्चा जब फर्स्ट टाइम जाता है किसी हेल्थ केयर सेंटर में, तो वो सिर्फ पोलियो पीने जाता है, ये हाल है। सो पोलियो अटेंशन इतनी हो गई है कि दूसरे डिजीज को अटेंशन ही नहीं दे रहे। तो लोग जो है ना वो बहुत स्केप्टिकल हो गए कि बाकी चीजों को तो कुछ नहीं सोच रहे, पोलियो पोलियो किए चले जा रहे हैं। And then inability to integrate polio vaccination with broader health services. This is the main problem कि broader health services को, meaning के EPI प्रोग्राम का हशर देखें 70% कवरेज, और आप पोलियो जो है अप्लाई जा रहे हैं, तो कैसे how मतलब जो पब्लिक भी जो है वो फिर स्केप्टिज्म हो जाता है उसके अंदर। So this is a polio story. So let's change gears and talk about a new virus in the town. ठीक है, आपको पता है क्या हुआ। सो HPV के बारे में थोड़ा सा मैं पहले थोड़ी सी साइंस बता दूंगी, फिर आई गिव ओवर टू Natasha. HPV, you all know, it's a virus which causes infection to mucosal and skin cells through intimate skin and sexual contact. Most common sexually transmitted infection. Very important thing is that by age 45, 80% of sexually active individuals harbor HPV in their genital tract. Okay. However, majority, they do not have symptoms and they clear the virus by themselves. So most of the common symptoms are just warts, that's it. लेकिन फिर 2008 में एक नोबेल प्राइज मिला था हमारे एक जर्मन डॉक्टर को, जिन्होंने कहा बताया कि HPV is an oncogenic virus. It causes cancer. So HPV अगर persistent infection हो, if the genital tract has continuously been infected with HPV, और new viruses genital tract में enter होते जाएं, so then there is a chance of development of cancer, and which all usually take 15 to 20 years or longer. So HPV is responsible for, it is found that HPV itself is responsible for 5% of all the cancers, not only cervical cancer, but anal, vaginal, penile, vulval, and even head and neck cancers. And there are 14 strains which are cancer causing. The most common are 16 and 18. And the risk factors for cancers are multiple sex partners, sexual activity at a young age, other sexually transmitted infections, or multiple pregnancies. These are the major risk factors. Others are smoking and early marriages, etc. But these are the major risk factors for getting the cancer after HPV infection. So this is the timeline. HPV infection जो है वो क्लोन हुआ था HPV 16 and 18 के कैंसर की वजह से, जिसकी वजह से नोबेल प्राइज मिला। एंड देन यहाँ पर गार्डेसिल एक वैक्सीन इंट्रोड्यूस हुई अमेरिका में 2006 में, जिन्होंने 26 इयर्स के गर्ल्स को, वुमेन को, एज वेल एज मेन को भी, बच्चों को भी वैक्सीनेट किया गया। और फिर इन्होंने प्लान किया कि हम जो है और इसको बढ़ा देंगे, तो ये सिर्फ बाइवेलेंट नहीं बल्कि टेट्रावेलेंट एंड देन 9 वेलेंट वैक्सीन आ गई। और फिर ये 9 वेलेंट वैक्सीन में सारे तरह के वैक्सीन है, कैंसर वाले भी हैं एंड वॉट्स वाले भी स्ट्रेन्स हैं। तो वो सारे के सारे जो है वो कवर करके हम इसको फ्री करेंगे लोगों को। सो WHO ने फिर कहा कि ओके, वी विल launch a worldwide strategy to eliminate cervical cancer through HPV vaccine. और प्रोजेक्ट ये किया गया कि 2044 में अमेरिकाज में खत्म कर देंगे एंड 2070 में जो है वो सारी दुनिया से खत्म कर देंगे हम HPV, ताकि हमारे पास HPV जो कैंसर्स हो रहे हैं वो खत्म हो जाए। इट्स वेरी एक्साइटिंग, क्योंकि सब बहुत सारे रिसर्च चाहती है कि कैंसर की वजह जो है ना वायरस निकल आए। तो 2-3 वायरस डेफिनेटली निकल आए हैं, जैसे हेप बी निकल आया है, हेप सी, EBV एंड नाउ HPV। EBV एप्सिन बार वायरस एक वायरस है जो कि सिंपल सोर थ्रोट कराता है, लेकिन वो भी जो है लिम्फोमास कराता है। So there are certain viruses, hepatitis B virus, hepatitis C virus, And then this HPV virus, so कुछ viruses आ गए हैं जो कि वैक्सीन जो कैंसर कराते हैं, and which is very exciting कि भाई वायरस आ गया तो उसका वैक्सीन हो जाएगा तो ये पेशेंट हमारे ठीक हो जाएंगे. तो this is the same thing. So HPV vaccine क्या है? This is there are 3 types of vaccines: bivalent, quadrivalent, and nine-valent basically. 3 dose schedule होता है, लेकिन 2 dose और 1 dose भी non-inferior है, तो we can give 1 dose schedule also. The risk of cervical cancer was lower in 88% of people who get vaccinated in a large population-based study in Sweden. So 125 countries have started having HPV vaccine among their girls, and 47 countries also for boys. ये सारा WHO का data है. And 9 to 14 years की बच्चियों को क्यों लगाया जाता है? Because the idea is to administer before the onset of sexual activity, that is before exposure to HPV. And with multi-dose, it is seen that the risk of the titers remain high for 6 to 12 years.
And would you say that's an important area also that requires follow-up?
Yes, yes, yes.
But
So-
then only single dose is recommended. When we see the different websites and different recommendations. I don't know in Pakistan.
Yeah.
People online will not be able to hear you without
Yes.
mic, but
Okay,
दूसरी
sorry.
चीज ये है that we'll take the questions after because some of these questions will be responded to.
Yeah,
Will be
this is a very
covered.
important question. Yes, the
I-
1 dose versus
yeah.
multiple dose.
Second speaker.
Yeah.
So WHO position paper आप देख लें, which is published in 2021, कि recommends that HPV vaccine should be included in all national immunization programs and should reach 90% of all girls by age 15 by 2030. WHO हमेशा 90% तक जाता है, हम तो 70% तक कभी नहीं पहुंच पाते हैं. Okay, and all currently licensed vaccines have excellent safety profile. HPV vaccination is a primary prevention intervention. This is very important, जो इन्होंने बहुत highlight किया WHO ने, that it does not eliminate the need for screening later in the life, since the existing vaccines do not protect against all high-risk HPV types.
Dr. Asma, if you don't mind, if I can add, कि वो जो prevention की जो table देते हैं, they talk of, sorry, just to point out, जो primary vaccination, primary prevention का ये जो vaccine की बात करते हैं, right next to it is the point that you're making, जो आपने bold किया है, which is also put as a secondary preventive measure.
Yes. This is a secondary preventive measure, and they said that vaccination is only a primary, but you should continue screening the girls and the women. So HPV vaccine should be introduced as part of a coordinated and comprehensive strategy to prevent cervical cancer and other diseases caused by HPV. This is a position paper of WHO.
And this screening has to be done on also maybe on those who have received HPV.
Yes, definitely. HPV vaccine plus this screening, not only HPV vaccine.
Yeah.
So, yeah.
Screen क्या होता है? What does screen mean?
Okay, screening means the
Pap smear test.
when the women or men, basically women become sexually active, they should have a pap smear. A pap smear is the test done through the vagina, and we see some cancerous cells in the on histopathology, that the precancerous cells, or even HPV virus itself through PCR. This is a screening method. So the Pakistan launched HPV vaccination drive because of all these things from 15 to 27 September. And now I'll give over to Natasha.
So, Dr. Natasha, over to you. You should have your ये इसको बंद कर दें slides. Natasha को right से right, Natasha over there. So I have to do that. Next slide. Dr. Natasha, if you could switch your camera and audio on. Unless we've
I think we've lost her.
lost her, that could be a possibility. You can
Let me
text her. So in the meantime, while we find Dr. Natasha in cyberspace, if there are questions,
Yes.
आपका ही सवाल था sir. If you could now, can you use the mic, please?
Doctor,
आपको introduce जरूर करा दीजिए.
Asha, my name is Abdullah Memon. I am working in a healthcare sector in a pharmaceutical company. I am pharmacist basically by education, but I am continuously involved in different hospitals and with the doctors and with paramedical staff even. अच्छा ये जो अभी हमारे पास चल रहा है आपने माशाल्लाह मतलब you have given very good brief of the the HPV vaccine जो ड्राइव चल रही है पाकिस्तान में उसके हवाले से जो क्वेश्चन मैं तो उस टाइम पे मैं आपको पूछ लिया था कि जो अभी ये एक्टिव इंग्रेडिएंट के थ्रू हम इसको कर रहे हैं इसको एक ड्राइव को एचपीवी वाले वैक्सीन को पोलियो के ऊपर भी कुछ बात हुई थी कि हमारे पास जो आपने एक और बात शेयर की थी कि यूरोप में पेरेंट्रल जो एंटी जो पोलियो वैक्सीन चली थी हमारे यहाँ ऑरल चल रही है ये अभी तक और फिर वहां पे यूरोप में अब शायद कंटिन्यूसली दे आर नॉट दे गिविंग द वैक्सीन पोलियो वैक्सीन टू देयर जो इन्फेंट्स हमारे अभी तक ये ड्राइव चल रही है और कुछ अनफॉर्चुनेटली हमारे केसेस भी रिपोर्ट होते हैं तो ये चलती रहती है अभी भी पेप स्मेयर के बाद टेस्ट के बारे में तो हमारे यहाँ लोगों में इतनी अवेयरनेस नहीं है कि टेस्ट क्या होता है क्या नहीं है जो हम इसको वैक्सीन तो हमने स्टार्ट कर दी है बट फॉर स्क्रीनिंग इसके लिए भी कोई इस तरह की चीजें नहीं है बाकी और कोई कुछ क्वेश्चन होगा या और किसी ने अगर पूछना हो तो डेफिनेटली वो
वो ओके आगे ये डॉक्टर नताशा
नहीं नो
अच्छा
You can
so
ask
आपका डॉक्टर अस्मा सो ये सवाल स्पेसिफिक आपने एचपीवी के बारे में आपने नंबर ऑफ वैक्सीन भी आपने बात
जी जी
सो पहले तो आपने कहा कि ओरल पोलियो और इनएक्टिवेटेड पोलियो की बात की तो बेसिकली इनएक्टिवेटेड पोलियो वहां पर रिकमेंडेड है जहां पर वाइल्ड पोलियो की सर्कुलेशन नहीं हो रही जहाँ खत्म हो चुकी है तो वहां पर वो इनएक्टिवेटेड पोलियो करते हैं इनएक्टिवेटेड पोलियो बेसिकली जो जो इंजेक्शन से लगता है वो आपको तो प्रोटेक्ट कर देगा बच्चे को प्रोटेक्ट कर देगा लेकिन जो है वाइल्ड पोलियो की अच्छी बात यह है मतलब कि ये कम्युनिटी को भी प्रोटेक्ट करता है कि अगर वो बच्चे को आप पिलाते हैं तो वो उसके स्टूल के जरिए वो वाइल्ड पोलियो जो एटेन्यूएटेड पोलियो बाहर निकलता है जब जब बच्चा वो मतलब गंदा पानी पिएगा तो उसको वाइल्ड पोलियो नहीं पिएगा बल्कि वो एटेन्यूएटेड पोलियो पिएगा वायरस वाला पोलियो पिएगा वो बचा रहेगा तो इस तरह से जो है वो ओरल पोलियो वैक्सीन इसीलिए अभी तक चल रही है पाकिस्तान में क्योंकि वो जो ये जो कॉन्सेप्ट है ये अभी तक क्योंकि वाइल्ड पोलियो एनवायरनमेंट में है इसलिए आपको देना पड़ेगा तो ये एक आंसर है साइंटिस्ट का कि इसलिए हम ओरल पोलियो को कंटिन्यू कर रहे हैं
Dr. Asma, can I add something
Yeah.
to this? I'm Dr. Nikhil Tejaz, general pediatrician. Actually, Dr. Saab, आप Dr. अच्छा, okay. Actually, हमारे यहाँ भी inactivated polio vaccine EPI में है in the pentaglobulin. So we are doing both. आपके जो 3 डोजेस मिलते हैं 6 वीक्स 10 वीक्स एंड 14 वीक्स पे उसमें आईपीवी एडेड है द रीजन कि हम ओरल को अभी तक नहीं हटा सके जैसे डॉक्टर अस्मा ने कहा है कि वो आपको हर्ड इम्यूनिटी दे रहा है ठीक है तो वो स्ट्रीट होगा और फिर अपने साथ बहुत लोगों को करेगा दैट इज लेकिन हम आईपीवी कर रहे हैं
ठीक है
कोई और सवाल है since they're having problem in connectivity is there any other question that there is
So, Dr. Asma, आपकी तरफ can the group also direct some of the questions about HPV?
Yes,
Yeah.
please.
Yeah, Natasha is online I think now.
आगे ही? Oh.
I'm so sorry. Assalamu alaikum, everybody. I apologize for that glitch and my disappearing for a few minutes. I got logged out of Zoom. I'm not sure what quite happened, but I've sent a request to share.
You
Can I-
Dr. Natasha,
do I
you
have-
you have it now.
Oh,
Yeah.
I've kept the
Go
record.
ahead.
Okay,
Yeah.
wonderful. Thank you, Swallow. Thanks. Okay. You should be able to see the first slide. Great. Okay, that's that might be very much today. Right. So the first slide is
Natasha, we can't see your slides. Perhaps we should run your
Okay.
slides from our side. Is that okay?
Can you see them now? I think the
No,
issue
no.
is my Wi-Fi and the camera together. So I'm
Yeah,
going
we
to
can't
just
see your
shut
slides.
off the camera. Can you now see the slides? Because
Nope.
my
Nope.
okay. All right. There
Dr.
was some-
Natasha, just
Can we go to
close your
plan B?
just close your slides and retry. We'll also get the slides over here, but can you try one?
Okay. Yes, I can stop and share and try again. Yeah.
We still can't see your slides, Dr. Natasha.
Why don't we?
So we should go to plan B, Dr. Natasha. We will run your slides if you're still with us. Are you with us? I think we've lost her again.
Yeah.
She's not online anymore. So
I'm back again.
Okay.
I'm back and I'm keeping the camera off. And I'm going to just try one more time, and then I'm going to, if it doesn't work, I'll ask
Okay.
you to share the slides. Okay, is that
Still not there.
not there? It's just the Wi-Fi from here is a bit slow right now.
Yes, we've got it.
Got it.
Got it? Okay, wonderful. Yay. Okay, I'm so sorry about that delay, but I'm really grateful to Dr. Asma for actually providing some fantastic background information and also really importantly sharing that last set of publications from 2021 where very detailed information about some of the barriers to the polio vaccine were discussed in that 2021 publication. So that was a good 4 years ago. But yet we find ourselves in pretty much the same situation today with the HPV vaccine. So what I'm going to try and do is to address some of the concerns voiced by physicians and the public about the vaccine, specifically sharing with you some of the incidence data that we have on cervical cancer from Pakistan, some data on the prevalence of HPV infection in Pakistan, which has also been up for a discussion in a number of forums over the last couple of weeks, and to address some of the facts being communicated and perhaps not communicated to the public and parents, which is about why is this being done? A little bit of my comments on the consent process that's been undertaken because this has been done at schools and certain healthcare facilities, what the consent process has been like, and some of the facts about it, the vaccine being having 100% efficacy and lifelong protection. A little bit about really what's happened in the wake of the campaign. It's now been extended, I believe, to the end of this week. It was extended, but I believe that now it's tailing off and it's closing off. The campaign is closing off, and really, what is next? So I'm going to start with two very interesting words that have been floating around over the last couple of weeks, because these words are usually, used when vaccine campaigns or any public health intervention is initiated. We've got whataboutism and cherry picking. So just to explain to you about whataboutism is, it's thought of as a diversion tactic by people running public health programs. And the issue is that instead of engaging with the HPV question, people are asking about other diseases. So what about diphtheria stockouts? What about the diphtheria vaccine? Fix those first. What about screening? Why vaccinate before you fund pap smear testing or HPV testing? And what about the side effects of the vaccine? So, you know, the program leaders who are trying to implement a vaccine program tend to feel that these are diversion factors and we're focusing on the wrong thing. But I think these are very, very important questions. And then cherry picking, which is selecting only data points that support a position and ignoring the evidence. And I'm going to share some of the evidence with you. And I think cherry picking happens on both sides. So why is this really, why is this campaign initiated in Pakistan? I think the WHO elimination program really recommends that all countries.
Sorry, Dr.
must
Natasha,
receive-
can you speak a little louder?
Oh.
Just a little louder. Thank you.
Yeah, sure. Is that better? Is
Yes, it is better.
Is that better? Okay, sorry. Thank you. So WHO recommends that in order to eliminate cervical cancer, all countries must reach and maintain an incident rate of 4 per 100,000 women. And achieving this goal rests on the three key pillars, and the three key pillars are Dr. Asma has already highlighted one of them, and Dr. Mozam also referred to the fact that there's not just one preventative and one recommendation from WHO, there are actually three. So vaccination is only one, which is 90% of girls fully vaccinated with the HPV vaccine by the age of 15. And they want to achieve that target by 2030. So we're 5 years short of that. Screening, 70% of women screened using high performance testing by the age of 35. And sorry, that's gone. By the age of 35, I think my slides are going a bit haywire. And again, by the age of 45. And treatment should be provided to 90% of women with precancerous lesions, and 90% of women with invasive cervical cancer. So these are the WHO recommendations. And we've only just begun to address this with vaccination in Pakistan. So moving on to the question of HPV in Pakistan, and what is the prevalence of HPV in Pakistan? Where have these prevalence studies been conducted? And then a little bit about what does 1 versus 2 doses of the vaccine do to this infection? So in this report published by IARC and ICO in 2023, there were 3 key statistics that were highlighted in this report. And I think these 3 key statistics seem to be doing the rounds in a lot of social media and print media. So essentially the key statistic is around about 5,000 new cervical cancer cases are diagnosed annually in Pakistan. And cervical cancer ranks as the 3rd leading cause of female cancer in Pakistan. And it's the 2nd most common female cancer in women aged 15 to 44. So let's look at a little bit more further into that report. It's really interesting that the report begins with this very nice table, which shows the incidence of all the cancers that are HPV related, not just cervical cancer. So we've got cervical cancer here in women, and they're showing the age standardized ASR of 4.67, which is slightly above the recommended of 4 per 100,000 by the WHO. And then we've got, I think I couldn't help but notice that oral cavity cancer, which is around about 10 per 100,000 in men and 5.19 in women, is even greater than cervical cancer. So this was actually from that same report. So I was interested in looking at a little bit more detail about this age standardized rate and the age categories that the report already also highlighted. So this is actually data from the Global Cancer Observatory, and they have very nice graphs and data sets that you can actually access free of cost. So if I just look at the age standardized rate of cervical cancer in women between the ages of 0 to 85 years of age, you can actually see this really nice breakdown. It shows the incidence on the left in blue and the mortality in red on the right. And on the left, you've got all the different cancers. Okay, so here, cervical cancer is actually 5.4 if we actually stratify across all age groups in women in Pakistan. Now, if we look at women between 15 to 44, the report was absolutely right. It's the third most common. It's coming down to about 2.9 now per 100,000 if we just focus on this age group of 15 to 44. But if I take it to 15 to 34, that I can't see it anywhere here. Here it is. Here it is. It's actually dropped down to 0.73. So really, it really does, I think, again, statistics can tell you the story that you want to be told. So we have to be very careful about how we interpret these statistics. And a better measure really is to look at the mean age of incidence of cervical cancer. And again, very few studies have actually been able to provide this mean age of incidence, but it's around about 50, between 50 to 55 years of age. So what about the prevalence of HPV in Pakistan? So I've got a table here, which I put together that kind of shows all the studies that have been done on HPV in Pakistan. I have not included studies that have been done on esophageal cancer or head and neck cancers, but I've included studies on cervical and anal cancers in this table. So the table looks at the study and the year that the study was done, the population in which the study was done, where it was done, the total sample number in that study, what the main findings were, and some notes about it. So overall, I mean, I think the most important take-home message from this table is that the studies that have been done, some of them, or most of them, are focused on looking at women with abnormal cytology or already diagnosed with cervical cancer. Very few studies have included women with normal, women looking for HPV in women with normal cytology. And equally so, women with gynecological problems. Again, any person coming into a gynecological clinic for a checkup or problems have been recruited into these studies, and HPV has been looked for in these studies. So what's missing from this is really that there's no national representativeness. So there's no multi-province population-based estimate of any HPV or type-specific prevalence. Adolescents and young adults, there is sparse data. I believe that data is now coming through. There is a study from Aga Khan in the community where they have basically examined younger age groups 9 to 14 and then 15 to 24 and upwards. So we're waiting for that to be published. But these are the most relevant vaccine cohorts. Rural and underserved provinces, again, there's an over-reliance on Karachi, Lahore, Islamabad, Pindi. There's little data from Balochistan, Interior Sindh, South Punjab, Gilgit-Baltistan, and AJK. Again, there's a minimum data for men with, and key populations. There is also no data on persistence. So we have no follow-up data to look at whether or not HPV is persistent in these, so all the studies that I showed you in the table, they were just single measurements at one point in time. These women were not really then followed up to see whether or not they get reinfected. So that again is a limitation. Another issue is harmonization of the method of testing for HPV. If you look across these studies, there's very heterogeneous PCR methods. There's no, they would be very difficult to compare results across laboratories. And again, the program, one of the other major concerns is that we have, sorry, one second, that there's little baseline. So, how do we know whether this intervention of the vaccine or this vaccine program is going to be of any benefit. We don't have any baseline pre or post rollout impact study designed for this. Or maybe if there is, it hasn't really been shared or talked about. So there is a need for long-term follow-up. That's not just something that WHO is advocating. This is advocated by lots of other institutes in the US. Johns Hopkins did a study to look at HPV vaccination and its impact on reducing throat and mouth cancers. But they even say even for throat and mouth cancers, it's going to take about 25 years to see the true impact on the vaccination on reducing the numbers of throat and mouth cancers. So they say that it's going to work to prevent oral pharyngeal cancers, but it will take time to see that impact because most of these cancers occur in middle age. And that's exactly the same with cervical cancer. So a little bit now about the single dose of the HPV vaccination and what we know about it already. I don't know why this line is there, but I've just suddenly got a line across. So years of observational data from incomplete schedules and new randomized trials. That's where a lot of the evidence is coming from. The key 4 studies that are often quoted to highlight the effectiveness of the single dose versus multiple doses coming from, India, Costa Rica, Kenya, and the Doris studies. So again, there are limits to these to the overall the interpretation of the results from these studies. They're a heterogeneous data set. They are direct non-inferiority studies and their endpoint of measurement. So the endpoint that they're using in order to measure how effective it is looking at these cancer lesions and the development of cancer. But the durability in all groups, including men and immunocompromised individuals, is uncertain. So there are ongoing trials, which we're still waiting to see the results of. But the key takeaway is that, yes, 1 dose is better than no dose, definitely. But again, it's really imperative that we choose, that the scheduling of this is within the right context. We monitor these individuals closely who are being vaccinated, and we link vaccination to screening and, again, to improving our cancer registries and being able to document incidence of cervical cancer. Let's see if I can go down. So there are a number of important considerations. One is the time lag. It takes decades for precancer lesions to develop into cancer, and the full impact of a widespread vaccination on cancer rates will only be visible after many years in bugs. And because of this time lapse, we need to make sure that we have ongoing screening because the vaccine cannot prevent 100% of cases, as highlighted by Dr. Asma also. It remains vital that we have early detection and timely treatment for any potential cases that still arise. So rolling out the vaccine and rolling in trust, before rolling out a new vaccine in the public, what should we do? Where do we see that, this whole process in terms of consent and forms and timing and content, where has this kind of gone wrong? And what are parents hearing or not hearing? And how are these rumors and how is the scaremongering building up? And I'm just going to talk a little bit about that. So, before that, I just wanted to, again, share another table. It's a big table. There's a lot of information here. But this table is really a summary of the studies carried out in order to, to explore and understand the attitudes and awareness and knowledge of people about HPV and the HPV vaccine. And I thought this was really interesting. If you just look at the groups enrolled in these studies, they're hard, there's only like maybe 1 study where you've got adults from Pakistan, otherwise university students, physicians, transgender women, men who have sex with men, interns, nursing staff. Again, not really clear that enough of the general public has been engaged in order to address the overall understanding and impression of knowledge of HPV and cervical cancer. So it's being said that the vaccine is 100% protective against cervical cancer. The best studies show a very large reduction in cervical cancer when girls are vaccinated before exposure. From England, from their national program, when the vaccine was given to 12 to 13-year-olds, it was linked to an 87% lower cervical cancer rate by the mid-20s, and 62% if it was offered to girls 14 to 16 years of age, and 34% if it was offered 16 to 18 years of age. So clearly, you know, the earlier that the girls are given it, the before, before exposure to HPV, the more effective the vaccine. And Sweden, again, vaccination was associated with a 63% lower cervical cancer rate overall, and 88% lower if vaccinated again before the age of 17. So there are, there is a lot of strong evidence to suggest that there is a significant benefit of these vaccines. But again, 100% protection against cervical cancer, that's a very bold statement to make. And again, to say that there's lifelong protection against this vaccine if you get it, if you get the vaccine, well, we're still waiting. We're still waiting for that data. I don't think that that's a correct impression either. So just wanted to share a consent form that was shared with me by a friend of mine whose daughter is 13 years old, and she got this from her school. So it's really basic. It's really just saying, okay, I give my consent, I do not give my consent. And there was no information about what this vaccine is or what it does or how it, what it's protecting against. So this was one school, and this is a consent form from another school. So this is great. It gives a little bit more information. So it says, the health and well-being of our students is our top priority. And now it's also the public health initiative by the government of Punjab from September 15th to 27th. We've got a vaccination campaign, which will be held all across Punjab. It's safe, it's effective, it will to prevent these types of cancers, and attaches a consent letter. So and we highly recommend that you speak with your family, medical practitioner or healthcare professional to discuss the vaccine. So this is again, but it just goes to highlight that there was a real sort of range in terms of the types of consent forms that were circulating in schools. So I just wonder how much assistance schools were provided by the government in being able to put together an information pack for parents, and a more detailed consent form. So again, what happened to the informed part of the consent? Something else that was very disturbing that someone shared with me recently was that at some of the schools, when the girls were having the vaccination done, some health officials who were doing the vaccination or were part of the team there were taking pictures of the girls for their records. And I think one parent actually got very upset about this and objected, but she was just one parent. We don't know how many other parents or whether the girls really knew what was happening here. Some health officials
Dr. Natasha, can I ask you just a question? Sorry for the interruption. These informed consents, when they were provided or parents were asked to it, who was actually administering this? Do you have any idea? Was there somebody from the health department?
No, this was left to the school to
okay.
This entire process was left
that's
to the
what
school
I thought.
to do. Yeah.
Okay, so that's again an important point. Thank you.
Yeah. Some health officials actually asked some schools for CNICs of fathers of girls aged 9 to 15 years. And again, the schools felt very uncomfortable with this request. Some school parents were told that the government was testing the vaccine. So you can begin to see, if you're a parent and you're not so familiar with, cervical cancer or the HPV vaccine, you start to begin to wonder, whether or not this is, whether or not you really want to get your daughter vaccinated. And then there were no details about the vaccine. So I had a lot of parents actually contacted me wanting to know who's made this, what is it, is it some parents who'd actually read up on the the non-valent, and they wanted to know, is this the one that protects against all HPV types? And I had to tell them, no, this is a bivalent vaccine. And again, parents were asking me, okay, is this just going to be one dose, or are they going to get another dose later on, maybe after 5 years? How is this going to work? So again, there was very little detail about the vaccine. And then we had our Federal Minister of Health on a interview on social media talk about the vaccine program. And also, he also actually had his daughter vaccinated with the HPV vaccine, but had the whole event televised. So just to reassure parents that, if I'm getting my daughter vaccinated, it must be safe, which I'm not sure is the message, or I'm not sure of the message or the appropriateness of that particular choice of activity. I don't think that that's something that I would have advised him on. But it's really interesting, and I want to thank Fareed for preparing this slide. And so there were lots of comments under, on the social media site after the interview, and lots of people, the public were making very interesting comments. So this comment was very interesting. Why are we getting it free? Can you explain? No one is concerned about Gaza children who are dying of starvation, and here we are getting free vaccines. That's strange. So here's they're questioning, the entire program. वैक्सीन पर बहुत सारी कंट्रीज में केस चल रहे हैं और काफी कंट्रीज में बैंड है. ये प्लीज आप मीडिया सेल रिसर्च करें और खुद सच सामने लाए. Government की teams भी research करें. दुनिया में कुछ भी free नहीं है. So there's nothing like a free lunch. That's a very, very interesting comment. So again, the issue about banning the ban on the vaccine, there are a number of countries that have incorporated the HPV vaccine into their national EPI program. And there are other countries that are in the process of doing that. There are countries, but no country has made this mandatory, because I think that was one other concern that I think the federal minister referred to Saudi Arabia, that the vaccination was mandatory there. No, it is not mandatory anywhere. Anyone who's criticizing this vaccine is because the fear of COVID, and one should have this fear removed by establishing the vaccine ingredients, checked from authorized. That's very, this is very, very good advice, and, very useful. Here's one. If Bill Gates is behind this, we all know he is no philanthropist. So that's interesting. There's bringing in the Gates Foundation funding, which is involved in a lot of vaccination initiatives. So, again, funding is an important aspect, understanding the funding, and also alleviating and trying to reduce that potential, even if it's a perception of a conflict of interest. I think it's important for independent research to come out, not just research funded by by pharma companies. So I'll come back to that in a bit. Why is the government all of a sudden so concerned about public health? Oh dear, that is quite cynical, isn't it? So I've never heard of this cancer in my entire life. So how every 8th woman is affected? So again, I think the statistics are being misused in this particular program. So why was it withdrawn in Japan, Denmark, even in the US? I don't think this is correct. I think Japan paused, but that was a very long time ago, around about 2013, 2014. But since then, they addressed some of the concerns that they had. And in Denmark, again, it's being used. We might inject men instead. Yes, well, this is advocated for men, for boys as well, 9 to 14. But right now, the focus has been on young on the young girls because again of the limitation of the number of doses. I wish they'd introduced a vaccine for more serious issues. So here's our whataboutism. But this is an important question. So I think questions are important and they shouldn't be dismissed by using terms like whataboutism. So is this like the COVID drama, get vaccinated or else be shunned from society? Well, hopefully no, because that we did have some mandatory, vaccine mandates that came about from the COVID vaccine. So that's not the case. So you are not researching enough. We don't have enough cases for this vaccine to be ruled out, see the causes. So this is advocating for more research. And again, comments about the fact that it is sexually transmitted, and this should be told to people as well. So it's really interesting that on the 18th of September, the former health minister made this statement. He said, mindful of the resistance in some areas, mindful also of the fact that we have had issues with polio vaccination. We've got 30-year-old history of that. And, Dr. Asma has just gone through that really so beautifully. And it would have been much better to have risk mapped the areas with refusals or hesitation to routine immunization, and communication and engagement activities should have been undertaken to remove any misgivings. A blanket start could imperil future gains in our quest to ensure 90% coverage. We should encourage modeling this vaccination through our kin, influential figures, children, and social media activists. So on the 25th of September, only 34% of the HPV vaccination target had been achieved, 34%. And this really is perhaps because of the fact that we really hadn't done our homework and reached out to the communities that were in the public the way that we needed to reach out to them. And sadly, I think one of the things that is really, really upsetting and sad is that lady health worker, part of the HPV vaccination team, beaten up in Mandi Bahauddin. And this is really, again, not dissimilar to what we've seen with the polio vaccine campaign. So where do we go from here? Well, it really is now an opportunity for us to do some serious engagement, find out what happened, why is there a lack of trust, how can we make it better? Plan to evaluate. We really need to evaluate these girls who've been vaccinated. We need to monitor them, not only we need to monitor them for their immune response, how effective and how long do these antibodies remain in circulation. This is really, really important. This should not be an isolated intervention. We should plan concurrent screening for women over 18 years of age. That's the pap smear and the HPV testing. More research is needed, and it should be independent from funding coming from pharma and organizations providing funding for the vaccine to avoid any perception of a conflict of interest. So that was my last slide. And I'm going to stop sharing.
Thank you, Dr. Natasha, for giving us the very broad overview. And I'm sure there's many questions online also. I'll just ask the people online. We have a lot of participants to put their questions in chat boxes or raise your hand. Of course, Kausar S. Khan has already raised her hand. So we can actually take her on if you have the ability to speak and have your video on, Dr. Kausar. We can take you on.
Thank you, Ahmed. Just in case my video opening disrupts everyone, I'll keep it as it is.
Sure.
I have 4 points to make. I'll quickly make them. I've written them in chat. I'll share the chat afterwards. First of all, congratulations to the two great speakers. I think the Pakistan polio story should be printed as an article because it reminded me of how Naila Kabir looks at why Bangladesh has done better than India and Pakistan in its family planning efforts and child survival efforts, because she gets into those nuances. Mention of informed consent was great, and I think that needs to be pursued. Now, my points are, I see this as a tussle between science and social science, because resistance to technology comes from our social norms, which are rooted in patriarchy. But there was no mention or uptake on how do you deal with it. Then as a public health issue, I want to raise the question, what is the relationship of public health with social norms? is public health to remain in the paradigm of science? Because in Pakistan, I find most of the public health domain remains within the scientific paradigm, whereas the contradictions and resistance comes from social science approach. If you look at the barriers that were identified and presented, they are all part of a research approach that is we call it the outsider's approach, the ethic approach. It is not the approach of looking at technologies and other things from the community's perspective, more of the. And Naila Kabir in her book has looked at research in Bangladesh, and she says until a certain point, all research was ethic. It was people from outside looking and commenting on people inside until the other type of research came. So my final question is, who's responsible for integrating social science issue with scientific intervention in something like the present issues that we've discussed? I've written this in chat and I'm just sending it now.
Great, thank you, Kausar. So, Natasha, would you want to respond to Kausar?
Yes, absolutely. Thank you, Dr. Kausar. So who's responsible to be the advocate to bring together the science and the social science? And how do we move forward? And I honestly think this is the public health department. This is really their responsibility. They are the ones who have to initiate an intervention. I mean, we're talking specifically about a vaccine campaign here, but it could be any public health intervention. So, public health professionals and teams, by definition, always have social scientists in their teams. Am I correct, Dr. Kausar? Because you've been doing this for years. So my response is that this should lie with the public health department.
Thank you. Thank you very much.
Any further questions from the audience over here or online?
We do have a question in the chat box, which I can read out aloud.
Please do that.
For the speakers. And so Dr. Afifa Ehsan is asking, can individuals who started with one dose schedule switch to another? Can they switch from one dose schedule to another? And what are the implications for vaccine efficacy? And then the second one, how do the different dosing schedules impact the overall effectiveness and safety profile of the HPV vaccine in preventing cervical cancer and other HPV-related disease? So Dr. Asma and Dr. Natasha.
Dr. Asma, can you take that?
Yeah, thank you so much. The best vaccine schedule is 3 dose, basically. The 3 dose has been studied a lot, and they have just like Natasha told us that the long-term follow-ups are not here right now because vaccine has just started in 2006. And the cancer appears 20 or 30 years after that. So the average studies till now is between 15 and 20 years. That's it, not beyond. So we don't know the exact efficacy of any of the of whether 3 or 2 or any other. And for one dose, still you are right. We don't know exactly what the exact efficacy is, but the WHO, because of the cost effectiveness, they recommend that start one dose and then we'll see afterwards whether it's really effective or not.
Sorry. No, you go ahead. I just wanted to add what Dr. Asma has just said, that the good thing about these HPV vaccines is that even with one dose, the antibody titer, like in other vaccines, it does not drop very quickly. It takes a lot of years to the antibody titers to come down. So even with one dose, it has been seen that the protection is equally good or not. It's not better than the 2 doses or 3 doses. It's very good.
Yeah, but connected to
the So connected to that, I think the main issue which has been pointed out by both our speakers is the stage so whoever asked the question is talking about efficacy. So efficacy in a vaccine like this, which first really came on the scene 2006 or so, at this particular point, to make any definite statements about number one, how long it will continue. These are things that are still being worked out. That's the first thing. The second thing is, in order to know how well this works, is the second part of the prevention, which is the screening, which WHO states very clearly. So therefore, again, even in the follow-up, if you're going to look at the efficacy of this, the rest of the preventive things, because the screening is also for precancerous changes.
Yeah,
So I think that is perhaps one of the issues, that this is still something that's unfolding. We know that there's been, at least so far, no real major adverse effects,
Yes.
although there's lots of myths, etc.
yes.
But the counter side of that is not to therefore say that we know it's all okay, but to be honest and upfront, to say even the issue of the number of vaccines
Yeah.
right now, so we can say the titer stays up for so long, but then we don't have longer follow-up to
Exactly.
do that. Okay.
Connected to this, Dr. Asma ने mention किया था vaccine, but vaccine is not a 100% prevention of cancer associated with this virus, right?
Yes.
ये हमने mention किया था, okay. And you had mentioned screening, right? So screening मतलब pap smear.
Yes, that's
So at this point in the country, do public sector hospitals offer pap smears for anyone? Vaccines अभी आई है ना, but अगर ये screening का हिस्सा है, if the screening is important, then this particular facility should also be available. There should also be some awareness. Do women of that particular age group, are they aware? जिस तरह से हमारे breast campaign चलती है, breast अक्टूबर की होती है ना ये, जिसके अंदर बहुत अच्छी campaign होती है, and women are, and men, everybody is told that, you know, there are certain measures that you can take to detect early cancer early. However, there is no such stress on cervical cancer screening at all. However, this is being rolled out. And we will never know if there is no screening and there is no routine pap smears in Pakistan. अभी तक नहीं है, तो अगले 20 साल में भी नहीं होंगे. So we would not know whether this has actually ever had any effect or not. We will never know this also. So ये एक बड़ा gap मुझको नजर आता है इसके अंदर. So वो, as you had mentioned, and also Dr. Natasha, that a public health rollout requires the public to be involved in the rollout. यहाँ तो it's been rolled over the public. It's a very good thing for the public to have access to potentially beneficial health interventions, but the public must know there has to be some buyout. Once you make this strike and that leads to a 30% or so uptake in the first round, it gets a bad rap, it gets a bad name. And the second rollout will be rolled out in an even more skeptical environment, which is why some homework would have been an important aspect. So how, Dr. Natasha and Dr. Asma, what could have been the a preliminary stage before the rollout of this HPV vaccine campaign?
okay. Can I? Okay. So my take on is this: as I have mentioned, our EPI program coverage, it's still much lower than our near neighbors like Bangladesh. Bangladesh has more than 90% of EPI coverage. So why should not we put all our money on strengthening our EPI, increasing the education of our mothers, because we found that mother education leads to less vaccination. So why not put all our money on that, and why adding more and more vaccines and making more and more confusion among the public? It's my take on. Thank you.
Natasha, would you like to add something to that?
Yes, yes, please. Dr. Ahmed, I just feel that the level of awareness that we needed to create amongst not just the public, but physicians also. And then you're doing this in schools, and how much effort was made to, again, really train the schools, or provide them with a template of a consent form, or, you know, I just feel these were still, your English higher end schools. What about your other public government schools? What I just dread to think what happened there. So I am very concerned about the lack of engagement that was done. And this should have happened a year before. Last year, we should have started talking about cervical cancer,
Right.
about HPV. And, we didn't do that. And then again, look, we've had terrible floods. We've had devastation in Punjab, in KPK. And then, all of a sudden, come September, you begin this massive vaccination program. So again, I think the timing, and then my other issue, and I hope that at some point, someone from the public health department can address this concern, is that, this is a good vaccine. It does provide, protection against HPV infection. It probably is going to be very important to have this vaccine in our population. But to me, it seems more like the push has come because, we are close to the 2030 deadline for the WHO. This has now just become a question of pushing out rather than rolling out a vaccine. And, whose agenda is this? I mean, if we really feel that this is an important health intervention for our population, then we should have addressed it like that, rather than just, just grabbing the girls and jabbing them. And, I feel that whole conversation is missing.
I have a question for Dr. Asma. That there is a science behind vaccinating from 9 to 15 actually, and because it actually builds the immunity and then prevents it. And the problem with this vaccination is that our outcome measurement is a cervical cancer, which occurs many years later on, and then preventive vaccine. That's why we are having doubt whether this is efficacy. So because there seems some problem with one dose is going to provide good immunity or not. With this in background in our mind, this doubt in our mind, aren't we denying a deserving age group? Because if we have doubt, let's wait for 5 more years, then the efficacy studies will be published. Just like this vaccination, which we are getting, is a WHO pre-qualified vaccine. This means long-term data will come later on. But then these girls are going to miss an important vaccination if they don't get it because of doubt in our mind. Long-term benefit, except you can say the long-term beneficial of this vaccinations, waiting for long-term beneficial may deny them a good immunity at this point, whether they get it or not. What's your take on this?
Very difficult question to answer, because yes, you are right. Women get cervical cancer afterwards, many years after, before they get the infection. And studies have shown that the younger, the early we give the vaccine, the more better. Fine. Yeah.
But is that related to when sexual activity begins?
Yes. Before, but the plan is to vaccinate them before they start having
Right.
Become sexually active. So it's really difficult to answer this, but my take on is this, that as Natasha has said, just 2% and 1% or 0.1% of the population getting the disease. So why putting all our money on just a smaller portion of this population? Okay, you can, but in my opinion, it's only my opinion, that you can argue with the donors that okay, we need vaccine, but for certain population only, not for the whole rollout, and the money for that rollout just give to us to strengthen our EPI. This is my role, my output.
I think Dr. Natasha does have something to say, because we'll let the speaker first. There are a couple of questions on the chat and also hands raised.
Yeah, thank you so much. Thank you, Saleha. I just wanted to answer the question about the denying the girls from. I don't think that I have stated or advocated that we deny these girls the vaccine, or we should wait for the data to come through. I think what we are saying is that we must be monitoring these girls. So if these girls are being vaccinated, it should not just be a question of कि बस हमने vaccine लगा दी है और बस हमारा काम खत्म है. No, it is really important to make sure that we keep monitoring these. Because how do we know the immunogenicity of this vaccine in our population? There have been maybe some initial pilot study that was done, but a considerable number of our girls are malnourished. So what's the immune response going to be there? So we need to have more data. I'm not saying that we should not vaccinate, but let's be responsible in the way that we do this.
So adding to that, I think one of the issues also is the way how this information is presented to the public. So the downside of this is, without further insisting on further screening, including for those who have HPV, that thing, you don't see that anywhere. In all the discussions and in all the stuff that has appeared in the press, it is just the vaccine. And that's something cherry picking, as Dr. Natasha had said. The danger of this is complacency. So if the information is that this is okay, this is fine, this is, do not deny this, and with that is the issue that this will prevent cancer, cervical cancer, whereas even WHO says very clearly, this is not just the one thing you have to do. And because WHO works from within the government, so going back to Kosser's point of view earlier as to who does this, and the response was that it is the health authorities when it comes to public health. So there's an element which I fear of complacency. So those who agree, oh yeah, okay, it's 100%, so that's fine. We've had the child vaccinated, as we do for diphtheria, etc., and this is it. You're finished with the whole problem. But cervical cancer is different, and we have not talked about the fact that the sexual intercourse, there's males involved in it also. So it's kind of complicated.
And I think what adds to the complication is the fact that cervical cancer screening and pap smears are actually not available in public sector hospitals. To me, that is one of the biggest injustices that we are doing to a lot of women. And as a parent, I would think that yes, you become complacent because the idea in the general public, someone who's not a medical practitioner or someone who does not know about HPV vaccine, is to kind of say, okay, you know what, I've gotten my kid vaccinated, I should just let it be. Now I don't have to do anything, which is, so for a lot of married women sitting around this table, for example, I don't know if I was to do a count how many have actually undergone pap smears, even those who are who can afford to go get that done in private sector hospitals as well, because there's not enough awareness that has been spread about it at all.
In fact, if you generally ask people about HPV vaccine, they'll have an opinion, positive or negative. If you ask them about cervical cancer, they will have an opinion, no cancer. But if you ask them, what is cervical cancer? Where is the cervix and the cancer? And they would not be very clear about that. Anyway, so if we have someone, Dr. Fayaz online, would you like to speak up, Dr. Fayaz, and open your camera if you can do that?
Am I visible?
You're not only visible, you're very welcome back to CBEC. He's an alumnus.
Well,
yes, Dr. Fayaz.
Thank you very much. A little bit my introduction, because some of you may know me and some of you may not. I am Dr. Fayaz, and I have been on the same tables back in 2016. And after a very long time, I will happen to be back on this forum. Actually, today's subject is, to some extent, is connected to the area where I am right now. तीन एरियाज का मैडम ने जिक्र किया, डॉक्टर अस्मा ने, these are the hot spot of polio. One of them is there in Karachi, another is there in Quetta, and third one is there where I am sitting right now. I am speaking from the southern KP at the moment, and my introduction is that I am healthcare administrator and as a profession, and I am at the moment commanding a hospital here in Bannu. combined military hospital Bannu, which is a 250-bedded facility. I'm just here for about a month here. So ek mahine mein I am going through a cultural shock as well. The discussion which I am listening is very urban to me from this standpoint. Very, very urban. Because HPV to bahut baat ki baat hai, we are fighting a polio. And in the meantime, Dr. Asma was giving the presentation. I gone through the data from the Bannu, and it showed me that there was a case from here as well of a wild polio virus in Shamsi Khel area. So what it actually speaks, the culture is vastly different. Vastly different. I am sitting in a kind of a different country at the moment. I am trying to understand them. If you go to bazaar, आप शलवार कमीज के बगैर बाजार में नहीं जा सकते. You will be alien. वजह क्या है? वजह ये नहीं है कि they are just different. That's it. We are different. वहां पर कुछ और लोग हैं, यहाँ पर कुछ और लोग हैं. The problem that I see is it's very challenging hospital. It's very challenging place to serve. The security environment, everyone knows here. I think the medical establishment is thinking on one line, and the other fronts, which is sometimes international, sometimes local, sometimes the government sitting at Islamabad is thinking on other lines. And these are not connected anywhere. आप बाजार में चले जाइए, 100% टोपी वाला बुर्का है, और no women is without that. It's fine for this region. Color coding bhi hai. You can define from the color coding of that burqa that this woman belongs to that particular tribe. So Bannu is a headquarter of southern KP, and it is looking after the Lucky Mawat, southern Waziristan, Tank, DI Khan. These are the regions from where I get the patients, and damage control surgeries being done over here and all that. So from the standpoint of this polio or other things, I think the region is still very volatile, very, very volatile. And it will take a very long time. Maybe not the approach which is thought about there at WHO headquarters in Islamabad. A different approach may be required over here. And that is, I don't know, because I have never met them yet. I met the commissioner, I met the DC, but I never met them yet with the health establishment over here, how they are thinking over it. This is my comment. Thank you.
So, Dr. Fayyaz, Assalamualaikum. Good to see you back in a way, virtually around this table. So, दो सवाल हैं. Polio के बारे में, as you're saying, it is quite volatile, and you said there has to be a different approach. So maybe polio के हिसाब से, maybe do you have any ideas? मेरा दूसरा सवाल आपसे था, within where you are now, has this HPV drive also been introduced there? So दो सवाल थे सिर्फ आपसे.
Not yet. HPV तो नहीं पहुंची अभी तक.
Okay. And polio?
Polio होती है, but
you have ideas?
In this particular year, there were 3 campaigns, and I have yet to see the Department of Health over here in the division to what they have done about it. But looking at the situation over here, even the people who have to come to hospitals, certain roads are not that open all the time, and there is a certain threat. So it's not that easy, even for people who are going through the gynecological issues or people who are going through the normal disease. What to talk of a vaccine that has to prevent a disease which is not even visible to anyone.
Yeah, that's interesting take. बिल्कुल बुनियादी मसले.
Thank you.
आपका सवाल था, sir.
Dr. Natasha, can you hear me? My name is Abdullah. I'm working in a pharmaceutical sector industry, and I'm a pharmacist basically. I'm not a doctor. But you were giving us a very good detail of this cervical cancer and its prevention and vaccination. But the question is, prevalence of cervical cancer in Pakistan. You shared a data of Dr. Natasha, are you here?
Yes, yes, yes.
Ji, Assalamu alaikum. Ji, I can hear you.
That's about prevalence. I am a father of 3 daughters. That's why I'm very concerned about this vaccination and this cervical cancer data. While I was going through the data on different websites, I found that only 5,000 cases have been reported in Pakistan last year, and only 3,000 deaths occurred in last year for this with the cancer, cervical cancer. And the campaigns I see on social media, anti-vax campaign and the conspiracy theories, rather I would say, कि ये वैक्सीन जो है वो नहीं है, वो यूं इतनी ड्राइव क्यों हो रही है, फ्री फंड में क्यों दी जा रही है. अच्छा, फिर डॉक्टर नताशा, यही कंपेन या एंटी वैक्स जो थ्योरीज हैं, ये हमारे जो पाकिस्तान के लिए सिर्फ नहीं है. दिस इज नॉट ओनली इन पाकिस्तान. When I see the different my friends and on others, वो जो यूनाइटेड स्टेट्स में वेस्ट में भी, वहाँ पे भी यही एंटी वैक्स कैंपेन चल रही है, वहाँ पे भी यही थ्योरीज चल रही हैं, कॉन्स्पिरेसी थ्योरीज चल रही हैं. अच्छा, फिर मैं देख रहा था कि जापान ने इसको अपने इम्यूनाइजेशन प्रोग्राम से निकाल दिया, इस वाले वैक्सीन को, ये एचपी वाले. नो मैंडेट, उसको बैन नहीं किया, नॉट अ बैन नहीं किया,
No, it's not
इम्यूनाइजेशन जो है
banned. Yes. Yeah.
कैंपेन से निकाल दिया है उसको पे. क्या
जी.
ये कि बट इससे इलेक्टिव है कि अगर जैसे
Yeah.
हमारे हेपेटाइटिस
It's your
बी है,
choice.
हेपेटाइटिस बी
Yes, it's your
इलेक्टिव
choice.
वैक्सीनेशन अवेलेबल इन पाकिस्तान, जिसको लगवा ले. Similarly, अच्छा डॉक्टर Natasha, still I'm confused about my daughters that whether should I go for this vaccination or not, because जो कैंपेन चल रही है एंटी जो वैक्सीन जो वैक्सीन कैंपेन चल रही है, थ्योरीज चल रही है,
आपका पॉइंट जो है बहुत इंपॉर्टेंट पॉइंट है. और
प्रिवलेंस
fact-
जो है इसकी बहुत कम है. सर्वाइकल कैंसर की मैं ये देखता हूँ कि प्रिवलेंस बहुत कम है. मतलब हमारी 25 करोड़ की आबादी में से ओनली
आपका पॉइंट बहुत इंपॉर्टेंट है. और जिसका और नताशा कैन नॉट गिव यू अ रिकमेंडेशन कि आप टीका लगवाएं या ना लगवाएं. दैट इज नॉट आल्सो द ऑब्जेक्टिव. द ऑब्जेक्टिव वाज टू एक्चुअली लुक एट द larger picture and see the various perspectives, and of course there's a lot of misinformation, and there's a lot of so there are myths, and then there are facts which have also been exaggerated. There's negative aspects and positive, both have been exaggerated, as if so.
Yeah, so maybe Dr. Natasha, maybe you can give your point of view.
I thank you, Dr. Mozum. So, देखिए, ये कहना कि only 5,000 women were diagnosed with cervical cancer and only 3,000 died. I think to begin with, it is 5,000 women who were, somebody's wife, mother, or sister. The issue is that when we start looking at numbers and wanting to have the numbers to justify a campaign, ये बहुत estimate है, ठीक है? We have no cancer registry in Pakistan right now. These figures of the age standardized incidence rate of cervical cancer, or for that matter, for any cancer in Pakistan, are taken from, hospital registries, are taken from, for example, the Punjab Cancer Registry. So ये बहुत crude estimates हैं because we have no national cancer registry. We have no way of really knowing exactly what the numbers are. But even then, even if the numbers are low, there is a vaccine that can protect you against this infection. And the vaccine works very well. The vaccine is safe. It's been proven to be safe. So I think the decision to vaccinate or not vaccinate, we're not, neither Dr. Asma or I would be in a position to tell you yes or no, but we've presented you with whatever data is out there for Pakistan in terms of cervical cancer and for HPV prevalence. So uske hisab se, I think that there's a lot to think about.
Yeah, I think exactly, Dr. Natasha. Okay, we just have given some facts both ways. Okay, and people have to make their own decisions. It is a difficult decision, but facts खुद आपके पास अपने ज़हन में होते हैं. It makes the decision making a little easier. Dr. Abdul Razak साहब जो हैं वो उनका हाथ उठा हुआ है. If you're online, if you'd like to make a comment, yes, thank you, sir.
Dr. Abdul Razak, I'm a general surgeon, and very nice presentation by Dr. Asma Natasha. I agree with Dr. Amir Jafri that about the screening of the cancers in Pakistan. And I see, I worked for more than 30 years in Black Medical Institute, I'm sure, as a surgeon. And as far as the screening is concerned in the peripheral area, I have seen the elephant tumors, even from the breast cancers and other cancers, the advanced stages, even after those programs available or not available. So this is one problem. Second is that instead of screening, we are offering the like it for hepatocellular carcinoma, we are establishing the centers of liver transplants. So this is the real scenario what we are doing in Pakistan. As far as the ethical issues are concerned, that you have rightly pointed out that we are not equally treating the every district or every locality for this HPV vaccine, and so that's why the ethical issue of the what we say the distributive justice and it is like a cherry picking. Thank you very much. This is all.
Thank you, Dr. Bharat. I think we've also come to the end of our segment time.
कोई यहाँ from this group कोई question है?
निदा का एक
Yeah.
माइक के साथ कमेंट जरा जोर से.
So what we have been listening to is a distrust. Is a distrust which results when public is not engaged. And the way cancer is looked at by our healthcare authorities. I think the biggest problematic point in this whole situation is the way cancer is looked at in this country. It is looked at as a single measure will take care of the cancer, whether it's breast cancer or cervical cancer or any other cancer. And the comprehensive planning to address cancers in this country is lacking. And I think that feeds the distrust, because when you do not have access to screening or treatment, and you take an injection and offer it to people, that ignites this.
In fact, this connects very well with the whole issue of mistrust with any vaccination or any public health measure. If the public health measure is imposed on the public for their benefit or for their health, even though it may have a lot of data for it, you will reap this harvest of mistrust later on. So that's what's happening right now. That's what's happened over here also. And then this is not just the one occasion. We've seen it so many times. People need to be engaged, and the engagement does not necessarily mean 3 advertisements in the newspaper and some social media campaigning. It requires a lot more than that of engagement over a period of a long time in different segments of society, so that people can then buy in and then have a choice. And choice does not necessarily mean a informed consent, which is administered by a person who himself or herself is unsure and does not know. And so the informed consent form needs to be administered by a person who understands what the informed consent is for, what are the things for in favor and against, etc. So all of this requires a lot of hard work. And as Dr. Asma and Dr. Tasha have pointed out and have discussed today, there are many aspects. We need to embrace vaccination and other public health measures also, but we need our public to be made aware of their importance, and only then will they be successful. Otherwise, great successful ventures will be bound to fail. Dr. Asma, sometimes, I mean, that's a great idea that we can ask for just a little bit of vaccine for this thing, but let's have the money for other things. The donors generally don't do that. Donors have their own agenda also, and there is an agenda behind various things, which I will not go into right now. That may require another forum in another place. But we must realize that they will only provide you what they want to provide you because they think that's good for you or good for them, whatever. But the fact of the matter is that it is a very large picture that we have to step back and look at it. And as I said, our population doesn't even know where the cervix is, let alone
cervical cancer kahan hota hai. So, but anyway, thank you very much for bringing in an academic discourse on a very convoluted and myth-infested discussion that is going on in the country on HPV as well as polio. I think this is you should take up Dr. Kausar's suggestion of writing this up also, both of you. So thank you, participants who came over here and participants who joined us online, and for your contributions. This recording of this will be available on our website in a couple of days' time. Thank you very much. Khuda Hafiz.
Khuda Hafiz. Thank you, Dr. Amir.